Thank you everyone for coming. My name is Kate. I'm one of the Sport Med residents if you don't know me already. The topic that I was given to discuss today for Journal Club was pediatrics. And so basically some of the big things in pediatrics are concussion, which we've already talked about this year, and also apophysitis. So I figured that I would go with talking about apophysitis. So this lecture is going to be focused on the conservative management of calcaneal apophysitis specifically, but in preparation for our exam and for other things, I'm also going to talk a little bit about the other types of apophysitis we can see. So as an overview, I'm also going to speak a little bit about bone development, go over the terminology of what an apophysis is versus an epiphysis, a brief overview of different areas where you can commonly see apophysitis, as well as go over calcaneal apophysitis, and then we've got our two journal articles to discuss. So in terms of bone development, there are two main ways that bones ossify or develop calcium and get stronger. So one of the main ways that I'm not going to talk too much about is called intramembranous ossification. And so that's basically direct ossification of connective tissue into bone. So there's no cartilage involved in this process. This is typically done with flat bones. So your shoulder blade, for example, or bones of the face, as well as your mandible and clavicle. And you can see the process on the screen there, where you have a mesenchymal cell that migrates and differentiates into osteoblasts and osteocytes. The osteocytes are more helping to support the bone, whereas the osteoblasts are building the bone. And then it starts with the formation of woven bone and then matures into lamellar bone there. But the big one that I want to focus on, because this is where we see apophysitis come from, is endochondral ossification. So this process typically starts in utero with a fetal hyaline cartilage model, as you can see there, more to the left, and they start to develop primary ossification centers, which you can see moving towards the number 3 there in that picture. And then as the primary ossification center starts to develop, you get less and less cartilage. And you also get secondary ossification centers forming at the ends of the bone, or the epiphysis, which is where the bones are articulating with other bones. And then that's where you get your growth plate from, which is still made of cartilage, which as the bone matures and ossifies, it slowly shrinks and closes. And then you get, by number 6, fully matured bone. So in terms of terminology, because I know this is something I've always struggled with, what is an apophysis versus an epiphysis versus, you hear all of these different terminology thrown around. So I thought this was a really good descriptor. So an apophysis is a secondary ossification zone, and that is formed where there is a tendon or basically non-articular surface. So mainly the areas where there is a tendon pulling on that bone and causing it to develop. Whereas the epiphysis is the secondary ossification center that is associated with a joint or an articulation. So for me, that was a big thing to just go over because I always was confused. So hopefully now you guys also know. And then in terms of apophysitis, so apophysitis is an inflammation of that apophysis. There are a few different theories as to why you get apophysitis. But mainly it is a traction injury to the growth plate. And two of the ways that you can see this happen is if there is a repetitive traction force, and this can cause microtrauma and inflammation, and then cause pain and swelling in that area. So repetitive traction force you can see in things like Osgood Schlatters. But the also in one of the articles we're discussing, they mentioned another way in which apophysitis can develop, because it can also be seen in more sedentary, more obese individuals. And they noticed the phenomenon of increased passive tension through that tendon and through that growth plate, just through how fast the bones are growing, and that the tendon cannot lengthen at the same speed as the bone. And so that's why you also can have increased traction and then the inflammation, microtrauma, pain, and swelling. And then epiphysitis, which, like I had mentioned, the epiphysis is the secondary ossification center at an articulation. That is more of a compressive or a shearing force. I'm not going to talk much about that today, but in brief, the common sites that you can see this in are the distal radius. You can see in gymnasts who are doing a lot of loading through their upper limb, and a lot of loading through that epiphysis as it's still there. And then you can also see the proximal humerus itself is also a zone of epiphysitis, just because of the shearing that goes through with repetitive throwing, sort of more called little leaguer's shoulder than little leaguer's elbow. And then this I'm not even going to really talk about, but epiphysiolysis is a widening of the growth plate under stress. So in terms of common areas of apophyses that we can see clinically causing trouble in terms of apophysitis, I have made a chart here, sort of areas that you can get if there's a name associated with it, average age affected, and when you can roughly expect the growth plate to close, although this has been quite variable throughout the literature as I was looking. And then sports to think about when patients present with pain in these areas. This slide is focusing on the lower limb, so you can see that the tibial tubercle is associated with Osgood ladder, as I'm sure we all know. The average age that I found were affected were 13 for men and 12 for girls. And then the growth plate closes between 14 to 18, but it has been shown to close even over the age of 20 in some people. So it's not as common to see Osgood ladders after the age of 20, but it's still something to think about. And then, as we know, it's more athletes who are involved in running and jumping sports are more at risk. The inferior patellar pull is apophysitis is called Sinding-Larsen-Johansson syndrome. Typically younger, between 10 to 14. And all I could find in the literature about when this growth plate closes is it said it closes at puberty. And the sports at increased risk for SLJ is football, running, volleyball, and gymnastics. The posterior calcaneus, which is the one that I'm going to talk about, is called Sever's disease. Typically somewhat younger children as well, 11 for girls, 12 for boys. Typically the growth plate closes at age 16. Again, seen in running and jumping sports. And then the fifth metatarsal, I hadn't heard of this one either. It's called Iselin's disease. And they described it as happening between 10 to 12, depending on the gender, and closes roughly 2 years after. And then for the rest of the body, we can see the list here. So little leaguer's elbow falls into that. And that's attraction apophysitis and valgus stress. So that's more of a UCL kind of tugging on that apophysis rather than a tendon itself. You can get olecranon apophysitis because of throwing sports as well. And then you can also get iliac ischial apophysitis as well. And the ischial apophysitis, the growth plate can stay open for quite a long time, up till the age of 25. The other areas that I did not talk as much about or go into the literature looking for the chart for this were acromial apophysitis and greater trochanter apophysitis, but those can also be seen. But why don't we focus now on calcaneal apophysitis or Sever's disease, which is an inflammation of the os calci here as it is developing, and thought to be caused by increased traction from your Achilles tendon and your calf muscles. So with these, patients may present with a history of either unilateral or bilateral heel pain, which is atraumatic in nature. And again, worse with activity, better with rest, and it may limit their activity and can be associated with a growth spurt. In terms of physical exam, you can see swelling to the Achilles insertion on the calcaneus. They may have reduced passive dorsiflexion, and then you can also use the squeeze test, which is squeezing the medial and lateral aspects of the calcaneus itself, and that can produce pain. That would be a positive test. And then Sever sign is just getting a patient to go up onto their toes and see if that produces pain too from the traction. In terms of risk factors, there are patient-related and there are sport-related risk factors. So obviously skeletal immaturity is a risk factor because the growth plate is still open. If your patient is 30 and they have heel pain, it's not Sever's disease. If, like I mentioned, if there was a growth spurt, boys are more likely to get it than girls. If they have poorly fitting or worn out footwear, if they've got heel cord tightness or are weak in their dorsiflexors, and then some other postural things that can affect our genuvarum, pes planus, pes cavis, and forefoot varus can all increase your risk. And then in terms of sport-related risks, if there's any increase in activity compared to what they're normally used to, that can also cause some irritation. Again, if they're involved in running and jumping sports, if they have year-round activities where they don't really get a break or get any rest, or if they're running on a hard running surface, it's also documented. And then in terms of the differential, again, think of what's anatomically in the area. They have Achilles tendinopathy, retrocalcaneal bursitis. They've got a calcaneal stress reaction or a fracture. And some of the studies looking at Sever's disease have shown that there is some evidence of stress reaction in the calcaneus itself, along with apophysitis. It was an MRI study done looking at those with apophysitis and seeing what the bones looked like, and they saw some stress. Could also be osteomyelitis, plantar fasciitis, and other studies and resources had said tarsal coalition could also be on the differential. And in terms of imaging, we know that Sever's disease is a clinical diagnosis. Imaging can be done more to rule out the differential. And one thing that was mentioned was to consider imaging bilaterally to see, to compare the growth plates from each side. And if you do end up doing imaging, an X-ray would show a presence of an open apophysis here, as you can see along there, and that it can also show some fragmentation of the growth plate here. So this is supposed to be solid all the way down, right? And there's sort of a big chunk missing out of it. And then again, if you're worried about other things on the differential, you can do a CT scan looking for tarsal coalition, or MRI if you're concerned about osteomyelitis or stress reaction or fractures. Not that I saw in the literature, no. Because it's more of a bony issue. It might show some inflammation around the tendon, but this is more related to the growth plate. In terms of management, currently the evidence for management for Sever's disease is quite low level, which is an issue because studies done looking at quality of life in children who have Sever's disease show that they have quite a significant impact on their quality of life. But in terms of things you can try with your patients, you can try activity modification. ICE and NSAIDs, you can try giving them a heel cup or a heel lift just to reduce some of that passive tension that's on that growth plate. If it's really bad and they're not responsive, you can try immobilizing them. You can try replacing old footwear, and then therapy directed at heel cord stretching and strengthening the dorsiflexors. And with this, it was listed recurrence is common. The study that I was looking at didn't list the rate, but they just said it was common. And then, as with most apophysitis, it resolves on the closure of the growth plate. So in terms of the journal article, the first one that we're going to look at is by Wiegerinck et al. And this is a randomized controlled trial looking at 3 different conservative management techniques for the treatment of calcaneal apophysitis. So they looked at wait and see versus orthotics versus physical therapy. And so their clinical question that they came up with, it was, is there a difference between wait and see, orthotics, or physical therapy in treating children with Sever's disease? The primary outcome that they used was a decrease in pain based off of the FACES pain scale. And then a secondary outcome was a patient satisfaction, and that was scored with a visual analog scale, and that had to be over 70. Or with the Oxford Ankle and Foot Questionnaire, which is a questionnaire that has been developed for children and for parents, and asks various aspects of the child's life and how much they're affected by their Sever's disease in terms of sport, in terms of their daily activities, if there are any issues with their footwear. And so it's just a standardized questionnaire that is commonly used, because we'll see it again in the next journal article. So in terms of their methods, these are their inclusion and exclusion criteria. So you can see that the main diagnostic criteria were a positive squeeze test, and they had a screening X-ray to make sure there weren't any abnormalities that would point more towards something else on the differential diagnosis. They wanted the patient to have pain for at least 4 weeks before the start of the treatment. They wanted to have a FACES scale of at least 30 millimeters. And they also had to be capable of performing the exercises that would be asked of them if they were to be randomized into the physical therapy group. They were excluded if they had already done one of the treatment modalities, if their age was not consistent with a likely diagnosis of calcaneal apophysitis, and if there had been any other injury or any other complaints related to other foot and ankle pathology. And these patients were recruited from a pediatric orthopedic surgery clinic. They were randomized in blocks of 12 by a computer program. They had allocation concealment with opaque envelopes. Only the researchers were blinded because it's very hard to blind the patients to something like this. And they had 2 follow-up points, one at 6 weeks and one at 3 months. So in terms of the interventions were given for 10 weeks. So wait and see was an activity modification intervention where patients were asked to stop any activities that were causing pain for 4 weeks or more, and then gradually return to their activities as their symptoms allow. They used a visco heel raise with no activity restrictions, but they asked to wear them in both shoes, even if there was only one affected side, and they asked for patients to wear them in all of their footwear. And then the last was physical therapy, which was focused on eccentric calf strengthening, and this required weekly visits with a physiotherapist to have the protocol supervised. And they also had a home exercise plan to do at home, and again had no restrictions on their usual activity. And so in terms of the results, they did not include the consort table showing which patients were lost, which ones were included. So I kind of just made this little flow chart here. So they screened 117 patients. 15 patients did not meet their inclusion criteria, and 1 patient didn't want to do the study. So they had 101 patients that they randomized and then lost 3 to follow up. So in terms of their baseline characteristics, there was no significant difference between the 3 groups. Wait and see had 32 people, heel raise inlay had 33, and physical therapy had 33 as well. And from their sample size analysis, this was significant according to their math. So the primary outcome was that there was no significant difference in pain between the groups, and all groups improved significantly between the 6 weeks to 3 month follow-up timeline. In terms of the secondary outcome, they saw that there was an improvement in their OAFQ in the heel raise versus the regular wait and see. And that was for what the children were rating. The parents had increased scores on the OAFQ for children undergoing physical therapy rather than the wait and see. And then in terms of patient satisfaction, the other secondary outcome, patients had a higher satisfaction level in heel raises compared to both groups at 6 weeks' time. But there was no difference in any of these at 3 months. And so the conclusion that they came up with were that all treatment modalities were equally effective, and they discussed some reasons why there may be improved satisfaction for the heel raise group. And part of that was that the heel raises had little costs associated with them, whereas having to go to something like physiotherapy does have a cost, and if you don't have coverage, that can be challenging. They also discussed that there was less time commitment. So the physical therapy group had to go weekly to see the physical therapist, and that was a time commitment that you just didn't have with the heel raises. And I think the biggest one, especially for the children rating it higher, was that there were no activity restriction, whereas the wait and see children were recommended not to do their activities. And so basically their recommendations were that physicians should have a discussion with patients about which choice works best for them, as all three of them seem to either work or not work equally as effectively. In terms of their critique, they didn't have a control group of children who would just do their regular exercise and continue on to see how they felt with that and do the questionnaires on them. Again, like I had mentioned, they didn't show any figure showing their recruitment and their randomization into groups. This also was not an intention to treat analysis that was done. The patients that were lost to follow-up just kind of floated away and were not accounted for anymore. And then there was also selection bias for children who were going to improve, because they excluded all of the refractory cases or cases who had tried a previous modality and were still having pain. So like I was saying, there is a selection bias as well because refractory cases were excluded. The other thing was that they had a relatively short time frame for assessment, so they stopped seeing their patients after 3 months. And then the other thing that they mentioned, although they didn't do an analysis of patient compliance, they mentioned that it would be challenging for patients to comply to some of these studies, especially over a 10-week period of, particularly for the wait and see group. And then obviously with these types of studies, it would be very, very challenging to set up blinding for patients, so only the assessors were able to be blinded. Okay.
Another question I have for the study is, who made the diagnosis of Sever's disease?
The pediatric orthopedic surgeons did.
Because it's a clinical which oftentimes it is. Based on the exam we were doing, it doesn't really exclude the other kind of diseases under differential.
Yeah.
How do you know that versus Achilles versus special?
Yeah. So it sounds like they were, that's another good point too. It sounds like they were mainly going based off the age, based off the story, based off the squeeze test, and then they did do an x-ray to rule out any terrible things, but as we know, x-rays don't rule out everything. Yeah, so that's another point to add there. The second journal article I wanted to talk to you about was effectiveness of footwear and foot orthoses for calcaneal apophysitis. This was published in the British Journal of Sports Medicine in 2016, and I believe that these authors are podiatrists who did this study. So their clinical question was, what is the effectiveness of different treatment modalities for calcaneal apophysitis? Their primary outcome was the OAFQ, so again, the questionnaire that is standardized for both patients and parents of children with calcaneal apophysitis. And then their secondary outcomes, they used the FACES pain scale, and they used the weight-bearing lunge test. So that's the test where you lunge the affected leg forward to see how far the knee can go over the toes. And they measured that distance. It's an assessment of kind of tightness in your calf muscles and also passive dorsiflexion by stretching, we'll say. So the interventions that they did were a little confusing. They basically wanted to assess whether a heel raise or whether new shoes or a non-custom orthotic would change these. So they created 4 groups, which was a heel raise and keeping the same footwear that they've had, a heel raise and giving them new athletic shoes that were supplied by Adidas, a non-custom orthotic, so just something you could buy at Shoppers or a store like that, with their current shoes, and then a non-custom orthotic with new shoes. Those were the groups that they decided to assess. Their inclusion criteria were children between 8 to 14 years old with posterior heel pain and a positive squeeze test. They excluded any lower limb fracture or orthopedic conditions, or any previous diagnosis or concern for any type of inflammatory arthritis or anything like that. They did a block randomization in groups of 4 to 8 stratified by site. And they did allocation concealment again using opaque envelopes. They had follow-ups at 1, 2, 6, and 12 months. And the clinicians were blinded to what group they were in. And so in terms of their methods, I wanted to bring this up because I found the statistics from this quite confusing as well. They used a generalized estimating equation analysis, which is a type of linear regression. And it's used to estimate the parameters of a generalized linear model with possible unknown correlations between outcomes. So because they were testing multiple different groups and interested in new shoes versus old shoes versus heel raise versus non versus orthotics versus none, they chose to do this model. And it can account for if there's any type of unmeasured dependence between a combination of factors. So this is their results here. So we can see that they've done their consort chart. And they had 124 that they randomized. You see one patient here made up pain to avoid sport, which was kind of sad when I saw that. But they had 31 patients for each of the 4 groups. And then they discussed how they lost patients to follow up there. So they ended up at 12 months with about 25 and 26 in the last group. And then these are some of their characteristics. So it didn't appear that there was any significant change in their baseline characteristic. Here. And then this is the results. I'm not going to go through all of this because this is a very busy chart. But as you can see from this result, they did multiple different analysis of multiple different groups at multiple time points. This is only the 1 and 2 months. It's excluding all of the other follow-ups because that was just too much. The one thing that I wanted to point out, though, here was that for only specifically the physical domain of the OAFQ, they state here that they noticed a preference for heel raise versus prefabricated orthotics. They determined that their p-value here was 0.04, so it was statistically significant. But you can see here their confidence interval here is minus 6.53 to positive 0.04. And so I just want you to keep that in mind, and we're going to talk about that. This was the only significant finding that they found. Otherwise, there was no significant difference between any of their other measures. So they suggested that there may be a benefit of a heel raise versus a prefabricated orthotic at 2 months, but no significant difference of any of the shoes versus new shoes or orthotics versus heel raise at 12 months. And that treatment depends on, again, cost and patient preference is also what they suggested. So their critique they also did not have a control group. They also, as you can see, they had quite a lot of analysis of their group. They did not assess the OAFQ as a whole. Instead, they broke it down to the different domains and assessed all of those separately. and did multiple different assessments between the 4 groups at each follow-up. And so this is concerning for me because it really increases the risk of something being found by chance as significant. And they just also had a lot of things that they were looking at all at once. And so there could have been a lot of confounding variables too. The other thing that I wanted to point out was that confidence interval for the main finding, and it crossed 0. And I'm not a statistician, so I had to look it up, but from what I was reading, and again, this is just very basic level statistics, that if a confidence interval crosses 0, then the finding isn't significant. Because including the value of 0 would suggest that there's no difference between the heel raise and the orthosis. So it just barely crosses 0, but it does. And so I thought that I would need to talk or learn a little bit more about confidence intervals to really make sure I'm interpreting that properly. But that having that value in there was concerning for me that this may not be significant.
What score was that? What did they do? Across 0?
So this was their confidence interval. This was from the GEE that they did, which was the linear regression analysis. And so I would need to learn more about what the GEE is and how to interpret results from that.
This is a negative score, right? So is that like a reduction in their thinking or something that they're looking at? Is it pain or satisfaction?
That was some of the questions about from the Oxford Ankle and Foot questionnaire. So asking questions in terms of physically how they're feeling and how they're doing. So yeah, wasn't too sure what to think of that. So I question the validity of the claim that they're making, but again, I don't have enough knowledge or background in statistics to really be able to say one way or the other whether this is true. The other issues outlined in this are the issue of compliance, especially for patients who are in the usual shoe. If they outgrow their shoes, or some patients lost their new shoes or didn't want to wear their orthotics, and they found that the compliance in general, again, I didn't put the actual number up, but it wasn't that great. And they didn't account for children outgrowing or losing their footwear. And so in terms of conclusions, wrapping this up, Calcaneal Apophysitis is a self-limiting condition, but does have a significant impact on patient quality of life. There are multiple conservative treatment modalities outlined in the journal articles today, which may be of benefit, but there was no specific modality that was determined to be better than any others. And so recommendation should be made off individual patient preference.